Welcome to the Veteran Summit, Dr. Shauna Springer. I am so thrilled to have you here and have many questions for you. But the first one I want to start with right away is that you are called Doc Springer by all of your clients and fans, including me. And I think of you actually as the PTSD whisperer, the mental health intuitive. So I know that that's a big honor to be called Doc. And I would love you to explain that story, how that first came about for you.
Thank you. It's good to be here, Jane. It is, as you said, just such an honor to be called Doc Springer. I no longer really feel anything much when people sort of talk about Dr. Springer, although I know it's important to establish, that one has put in the time and has the background and the credibility. I honor that, but at the same time, as my approach to practice has evolved, being Doc Springer has really come to mean the world to me. Yeah. And this interview is actually happening at a very interesting time because I got a call from a former patient of mine. Not from him, actually, it was from his wife because he had died of a heart attack. And his memorial was this past Saturday. And he was one of the first people to call me Doc and to explain to me what it meant. And so after I had transitioned out of the VA, he actually found my address and sent me a letter that, I still have, and I cited it in my book Warrior, but in that letter, he explained, what the difference is between a doc and a doctor. And what he said was that in the military, there's MDs that you referred to as sir, and then there's medics that were unproven, who were called medics. And then there were the ones with medical training who could treat and heal the soldiers regardless of, how bad it was, or would try their best to do whatever in their power to save or support that soldier. And they were called Doc. And he said it was because the help was guaranteed when you needed it the most. And so this interview, this conversation is happening at a time when I'm actually pretty fresh in the grief of losing somebody very precious to me, which is itself a bit of a change up from how I was trained, because the way that I was trained was to, be very kind of conservative and objective, and maybe to feel, I think I learned to feel a little bit detached from the work. And what I learned is that that's just not going to be helpful to engaging the trust of those I serve. And that even if the relationship isn't about you, it's still a form of attachment, and you still really, if your heart is in the work, you're going to feel grief if you lose a patient, or if you have to, stop seeing several hundred patients, as I did when I transitioned out of the VA. That was a very difficult process. But that's what Doc means to me. I'll stop rambling.
That's beautiful, though. That is such a tribute to you and to the incredible work and care that you give to all of your patients. I wanted to talk about your experience at the VA when you first were starting out. And as I had mentioned earlier, that you have this gift to be able to see what's not there in front of you, what's the missing piece. And I think that while you were watching the intake process and the response from the veterans, and that their mindset was, okay, this will be my last visit here, and their plan not to return, that you wanted to resolve that and understand what is the dynamic that's going on for them that is creating this resistance, this stigma. And you came up with lots of different ideas. I mean, you saw it and knew what you were seeing and translated that into a place where it was no longer in their way. And I thought that was so fantastic. And I'd love for you to talk about that and how you went from, the authority, the using psych jargon, to someone who used the military language that they were familiar with to begin to speak with him in their language. There were so many examples like that, but I would love you to discuss that, how you did that.
Yeah, so I think one of the things that helped me develop that perspective was that I had come from a position of having a private practice right before I came into the VA. So in my private practice population, I was mostly seeing relatively affluent, successful business leaders and people for whom therapy was a bit of a badge of honor, something that they were proud of, that they had the time and the ability to spend the money to examine their lives and to grow with the help of somebody that had expertise to help them do that. So it was like this mentality of, I have my dentist and I have my mechanic and I have my top shelf therapist. That was the mentality of my private practice patients. They greatly valued that time. And when I started working in the VA, the nonverbals, the verbals were even very different. It was basically, I'm only here because my wife told me I had to come see you. And many of my patients were looking for any reason I could give them to never see me again. So it was a very different feeling. And in fact, I'll tell you, this is interesting, back in 2008, I said, I want to do a little study of women who have graduated from Harvard. I was trying to understand how they set up their lives and their relationships. And so I did something called the lifestyle poll. And it was 200 questions. I had no budget, it was $500. So I got a SurveyMonkey account. And then I created this measure that would be intrinsically interesting to them. They would learn about themselves in a personal growth kind of way. And 1,200 women filled out this survey within 8 months with no money, no payment. They were intrinsically interested in learning about themselves. And in the sample, about 50%, maybe more, I think it was more than 50%, said, yeah, I go to therapy. It's something I do as part of my wellness. So I had this comparison of, sort of like the people in my Harvard tribe and people that I was serving in my practice as a comparison group for when I came into the VA, and it was a very, very different feeling. So I started to think about, who do they see me as? What have they seen people like me as in the past? Like, where does psychologist fit in the bucket in their mind? And when I went down that line of thought, I realized that there are very good psychologists in the military setting who care about their patients, and they serve a dual purpose. They're not there just to grow people in the same way that, we are in the VA or another practice to help people heal and grow. That's our only mission. The mission of the people who serve in the military is both to support wellness, but for the greater mission of troop readiness. They're also looking out for that. And so they get pulled into, as part of their jobs, fitness for duty evaluations, processes that result in people getting medicaled out of the service, and pulling them in on these roles has given people the sense that a meeting with a psychologist might result in very negative consequences for them, of getting pulled out of their unit or flagged or even taken, and medicaled out of the Army or the military.
Sure.
And so when I looked at myself from that perspective, I thought, oh, okay, that no wonder I don't even come in neutral. Here. There's a huge deficit in trust that I need to think about, how do I bridge that deficit and earn that trust? So I can share lots more if you want, but I want this to be a conversation, so I'll stop.
Well, I just find that so remarkable. You think of all of the people that have been treated, and the fact that you would take that and say, wait, let me see. I mean, it's so empathic, that you're saying, well, what must they be thinking? How must they be perceiving me? And to try to reach them and say, well, then I'm willing to make this adjustment so that they can feel comfortable. And I mean, safety is such a huge component in therapy because it's your most intimate self that you're exposing, and you are immediately saying, I want them to feel safe and that they can trust me. And I think that just says a lot about your skill. It's just extraordinary that years can go by and here you are, and presto, you see such an incredibly basic and important piece of the relationship between the veteran and the therapist. And that is really, really the beginning, isn't it, of the whole relationship, is being able to create that sense of, I want to understand them and make them feel comfortable. One of the things, go ahead.
I want to say something good about the VA here.
Yeah.
Here I go. This is it. It's very hard to work in a system where the people that you are serving enter from a deep deficit of trust.
Right.
And the person that I replaced was also a civilian. He had never served in the military, and he had earned the trust of the patients that he saw, that I inherited from him. So here's the thing about the VA and any healthcare system out there, doesn't matter which one.
Right.
It's full of people. And some people in the VA are extremely mission driven. For me, the VA was my way to serve. With what I had to offer, I served 8 years to the day on purpose. I started on my birthday. I ended on my birthday 8 years later, because it was like 2 enlistments. I said, no matter what, if my personality isn't a great fit for maybe a big system, I'm going to stick it out, because I didn't want to be a therapist that built the trust and then left, built the trust.
Right.
And left, because I saw that as such an impact on so many of the patients I inherited in those. They were angry and they had attachment wounds from losing that therapist. And so many of the patients I came to see would say, I don't want to start all over with someone else. I don't want to tell my story one more time to a new person. So I committed in advance for staying for 8 years. And I had some wonderful colleagues at the VA, very mission-driven people. And I'll share something else with you that I don't think I've publicly shared. My last performance bonus for the VA after 8 years of service, I had them spend that money on buying a picnic table for my colleagues at the VA. I wanted that picnic table to be on the back porch. They bought a really nice picnic table that could seat about 8 people, really good quality. And I wanted that because symbolically, I just want to balance the picture that this is really hard work that we do. And there are people that are doing this work in the trenches of mental warfare in the VA with huge caseloads, doing the best they can do. And some of them are docs. Some of them are amazing individuals. Some of my colleagues were just top shelf. And so I just would say to people, get out of the abstract of whether a system is good or find the right people in that system, and they can change your life.
That's wonderful advice. That's wonderful advice. And being able to have somebody come in and see where the system isn't working as efficiently as it could, and being able to make those changes is really fantastic. And you were able to do that in several instances. And one of the ones that I particularly enjoyed was with the peer relationship partnered with the therapist to help bridge that the gap in trust and respect. And if you could talk about that, that'd be great.
Yeah, I mean, there are like a few things I feel like the VA has really innovated on that they don't get enough credit for, because people often don't understand the VA is not really allowed to like toot their own horn. So one of those things was telehealth. They were far out in front of everybody else, and I was on the front end of getting telehealth going in my clinic. Another really innovative thing that the VA did was the peer support specialist hires. So at a certain point, they started hiring veteran peer specialists to come and be embedded in mental health clinics. And so I was in my clinic, I was the first mentor for our first peer specialist when that program launched. And that was so much fun. And that was like, I loved that partnership that we had. And we did so many innovative things with that. And my clinic manager, who's still at the VA, was amazing. Dave Chu, if you're hearing this, he's amazing. He is amazing. And he serves as a Army National Guard member, reserve member. And so he would, sometimes be deployed, but most of the time, there, and he really gets it and was supportive. So he really let us innovate. And so we together, the peer support specialist and I, we did a number of really cool things. One of the most impactful things that we did was we started a new patient briefing group. We realized that, just like we pull back and say, who would I be to these people I'm serving? How would they think of me? We realized that people really didn't have a lot of interaction with mental health providers or systems of care in this way outside of the military. And so we had to really help them create a map in their mind for how to navigate the system within the mental health clinic and what services and supports we offer. So I would go over to the new patient orientation for all patients in the hospital, regardless of whether they thought they needed mental health services or not. And I would give like a little talk about mental health services, but really try to help people understand that you can come in and get help with smoking cessation. You can come into my Wednesday group and I'll teach you how to have a good fight with your partner. There are all these like low stigma services that we offer with no obstacles or barriers. Just walk in. These are drop-in groups, and really told them like, you can come into our new patient briefing group and we'll tell you how to navigate our system and all the things that we offer. So then they would come from the general orientation group into the new patient briefing group that the peer and I hosted. And it was really cool because they would come in and we would present to them, here are the services we offer. But more importantly, what we were actually doing is putting on display what trust looks like between two people that hold respect for each other, a peer and a psychologist. And when we treated patients, he and I, we treated them as a team. And so I would sometimes see them for a little bit, and then he would take a piece of the work. He could do things with them that I couldn't do, which was interesting. He could do what we called walk and talks. So he would take them out on a hike. And then I was like, can I come sometime with you? Like, I don't think I ever went alone with a patient. But with him, a couple times, like we took somebody when they were really stuck out on a walk and talk together. And boy, didn't they just open up. It was like a whole different thing. And we just reached a new level of trust. And so we did all of these really effective things. Yeah. And it felt different because it wasn't just me and the veteran in a room. It was the veteran had now two people, which feels more like a team behind them. Right. It shifted the whole dynamic, just adding two people to the mix. So that was one of the really, really cool things that I got to do during my time at the VA.
That was fantastic. And are they still doing that now? Do you know?
Yeah.
That is so great. Yeah. And it's like you had your own little tribe, yeah. with a 3-person tribe. That is just so great. And I can imagine that would shift the dynamic by seeing the relationship between you and the peer, that there was not the power differential that I think is often where you feel the fear that you're going to have to give over yourself to another authority. everybody's here. We're all fine. We're all safe.
Yeah.
We're all together. And especially if you're out hiking, I can imagine that would be really good therapy. And one of the things I wanted to also mention, and I have to show your book because I absolutely love your book.
Thank you.
For anybody who wants to not only understand what is going on with a veteran, what is happening in their transition, what they are feeling, what they are thinking. It is such an intimate portrait, but it's also a textbook in the sense of really having to question yourself. As a civilian, I look at that and I think, gosh, I don't know. Where have I been? I don't know any of these things. And instead of just saying, thank you for your service, that connection is so important in welcoming a service member home, but also to understand how to do that carefully and thoughtfully so that you're not doing something that's triggering or and to really have much, not only did they sacrifice their lives to protect us all, but when they have come home, we're responsible for that homecoming just as much as anybody because we sent them, and we have to take that responsibility. And I think this book really helps to make us aware what a huge sacrifice they have given and how powerful it is. And we have to do more, just as human beings, in the connection. And it's just made all the difference to me. And I would love for people, there's a quote in there where you said we do more talking about warriors than walking with them. And that's really true. Other than military holidays, waving a flag, it's like, well, do you even know a veteran? And I didn't until recently. And so I really wanted to make the connection as a civilian and do something as a civilian that I thought might help. And that's where this whole Veteran Summit's coming from. But you were going to say something?
It's just mind-boggling sometimes the way that people will say to veterans, Happy Memorial Day.
Yeah.
Right? It's not a happy day. It's actually a day when they may be in deep grief and they're carrying 1,000 pounds of grief in many cases. TAPS, Tragedy Assistance Program for Survivors, does a lot of really important work in this area. But it's what you say is so true because, what breaks my heart is that I really don't think that today's veterans, despite all of the hero worship, really don't think they feel any better understood than Vietnam veterans did. Yeah. And so it's the same alienation and feeling like a stranger in a strange land. And until we understand and see them as people, many of them will feel like ghosts walking through our culture, like they're invisible and people are not seeing their pain. Some of it is that, warriors tend to hide their pain until you build the trust, and their trust is sometimes challenging to earn, but many of them would be, so grateful for the chance to open up and talk about some of that pain with a person who is worthy of walking with them, who is safe and who will be respectful. And so Warrior was really my attempt to connect with all of the other docs out there to say, find me, let's build something. Let's create a coalition of docs. And you know what? Let's train them up. I want this to be a textbook. I can get way more didactic and, clinical than I did in the book. I wanted to include lots of stories and hopefully make it engaging so that anybody could get something from it. Absolutely. But I would love to train up social workers, future psychologists, people that are wanting to serve veterans. This is what I've learned about their hidden pain, and here's how we can really help them. That was a core dream of mine when I wrote this book. So it's been hard bringing it out in the midst of COVID.
Yeah. It took you 10 years, so isn't this like 10 years of comprehensive work, that's now embodied in this book? It's just remarkable.
A decade of work, and I brought it out right in the middle of a pandemic health threat. When understandably, that's the focus for many people. They're just really, but you know what I learned, Jane, is that this was the interesting thing. So much of what I talked about in Warrior actually now applies to so many Americans in terms of trauma.
Yes, exactly. And that's why I hope everybody reads it, because it does. I mean, I think everybody's traumatized. I think at the root of everything is trauma. It appears to me, from what I'm understanding of it at this time. And for us to be able to know how to communicate with someone, let's say it's a sexual abuse survivor, in the military, they're still having a really difficult time. And to be able to know that you can communicate, that this will help you to communicate with them. For me, as a civilian, to try to come forward and say, I want to help, and I've had this much education. This is a lot of education to be able to help people. And I think that's something I really want to encourage people to do is you may not be a veteran. You may not have a veteran member in your family, but you owe it to them to understand them, because they are doing this for you. And it is the ultimate sacrifice. So I feel, I don't care if COVID's here. We're still getting this out to everybody. So have no fear.
It's an interesting thing as well, because sometimes when people feel like I owe it to someone to do X, it creates for us some internal resistance.
Mm-hmm.
You're not going to tell me how to use my time and energy. Can be a feeling that people have, not me, but just in general. And so here's the thing, like, it occurs to me in the context of COVID that what I see the tribe of military veterans and service members do so beautifully with each other, create and hold these bonds of trust,
Right.
is what we actually need to be doing for each other. Yeah. And what is missing in civilian society is what they're reacting to in the transition out of the military. So my pitch would be actually that veterans and service members have taught me more about love and trust than I ever learned anywhere else. And being part of their circles has been absolutely life-giving to me. And that I hope we can learn from them what this looks like and feels like, not just so that we can give them overdue support, but so we can support each other much better than we do now. That's what I think would be so important to take from this and apply, because I feel like all of us are kind of running on empty after this year of like layer after layer of trauma and bad news and, change. Like, this has been a year of massive disruption for us. And so knowing how to connect with and support each other is pretty much the most critical thing for us to focus on, I think.
Yeah, I totally agree with you. And I would love to sort of transition with that thought into all that you were saying about attachment theory, because I find that fascinating. And I think that really dovetails with what you're just talking about, is that we're detached. We're all, well, first of all, we're all isolated in our homes, but we're reaching out in other ways. But it's a sense of humanity's detachment. And I think that you're speaking about that, and what it can mean applies equally to a trauma survivor who will withdraw and not want to talk and all of that. So I'd love to hear more about that.
Yeah. So I really had a background in attachment. Before I came into psychology, I'd done some research on some of the attachment studies that were done out of Harvard University pediatric departments, looking at how children, in this case young children, are attached to their parents. And so I had that model going in, and then got interested in romantic relationships and thinking about adult attachment and how sometimes childhood patterns show up later in adult life, sometimes how trauma can totally change your attachment style.
Yes.
One massive trauma can take you from being securely attached to a form of attachment that's chaotic or insecure. And so thinking about the combination of trauma and how we connect or fail to connect with others has been kind of the overarching theme in my entire 20 years in the field. So when I think about transition from the military, I really apply that framework to it and think about it not as the time when you need to get your next paid job or to say goodbye to your previous coworkers and find new coworkers, but it's actually, in my perspective, an attachment wound, or if you want to say an emotional amputation from the family that gave your life structure and meaning. And that emotional amputation happens. I was just talking on the Vet Pivot Nation podcast this morning with a couple of veterans about this. It happens whether you decided to leave, whether you got medicaled out, or whether you get dishonorably discharged. Even if you choose to leave, the impact of that trauma and the identity crisis that can happen during transition is a punch in the gut.
Can I back up 1 second? Because even before you are deployed, you can enter the service with ACEs, adverse childhood events, experiences that can so traumatize you that you flee your family and join the military, because that's where you'll get the basics will be met: food, clothing, shelter, order, discipline. And so that may be all they've ever known of love and safety. And so I can imagine even the strain of recognizing that you were so, your universe was ordered, and now you're just naked and have no idea how to function in this other sort of too free, too loose, what do I do kind of thing. And that's why so many redeploy, because they're so uncomfortable.
Orphaned.
Yeah, that's right. That's the word you used that I thought was fascinating. Yeah. Orphaned.
After coming out. Yeah. Sometimes I would say abandoned, but that implies intent. And there's no intent, on the military's part or on the people that still love them who continue to serve in the military, but they often feel nonetheless orphaned. And the thing about it is that, as you say, many people who have adverse childhood events are drawn to a lifestyle where there's order and predictability, and they're seeking a place where there are rules that they can understand, rules that will be applied. And the military can be wonderful if you end up lucky enough to end up in a healthy chain of command. If you have a healthy chain of command, it can be a wonderful way to have that structure, to shape an identity, to create a sense of power and responsibility for your life that will transition you into success after the military. And you can have wonderful leaders and mentors in the military. So that is true. And if you're not in a healthy chain of command, let's take the worst case scenario and think about how high the stakes are here, right? You come in with adverse childhood events, and then you get hazed or sexually assaulted, and there is no justice. Let's just say, I'm not saying there's no justice ever. I'm just saying, let's imagine there's no justice. Then you came into a system where you were seeking rules, predictability, structure, protection. Maybe you were seeking to become the person who could have defended you as a kid by turning into this powerful warrior, and you ended up getting hazed or sexually assaulted. Think about the level of trauma that would create for someone. And that was common. among patients that I saw, male and female, males as well, had sexual assault and abuse of power as part of their history sometimes. And so it can go really great, but it can also be just really a high stakes environment for identity formation.
Mm-hmm. I think that sense of having to power through, suck it up, deal with it, and not to be able to get help, though, it's not something you can escape. It's the trauma is going to come back, bubble up somewhere at some time. And I think that being able to discuss with you and feel safe enough to be able to discuss with you all of these really intimate things is counterintuitive to the warrior way, thinking that is not brave. And I would love to go back to how you translate their language of courage, bravery, honor into their life as they're transitioning, so that they can use these skills, words, so that they can identify the skills into civilian life, and recognize how they can operate and use that skill differently than they had thought it might be used. If you could talk about that too.
Sure.
Yeah.
I would say, if I analyzed my thought process on that, the first step for me was taking it well out of the typical clinical frame. Because as long as I stay within the typical clinical frame, there's a set of assumptions and expectations that will come from that for me and for the patient I'm serving. So taking it out of the clinical frame and drawing from my background as an English major, pulling in stories and narratives was really helpful. The one that was really most helpful for what you're talking about was the legend of the Boy of Sparta. And that was really in Warrior in my book. That is like one of the central narratives that I used to ground the whole arc of the chapters and really the work that I do. So the Cliff Notes version, for those who are unfamiliar, is that the Spartan culture is very stoic, and they would have lots of emphasis on training for war, from a young age for the Spartan kids, boys mostly. And there was a boy who stole a fox and put the fox under his cloak and went to school. And the fox got hungry and started to eat his stomach. And because of the Spartan stoicism, he didn't say anything. He just sat there while the fox continued to eat his gut until he dropped over dead. And so that, to me, was an analogy that warriors can understand outside of the clinical realm for what is happening when those they love like family die by suicide. That many times they don't see it coming, because if they had really seen the risk, they would have done anything to get to that person, to get into that trench with them, to help them through that. And so I try to shift this from, the burden is not just on other people having psychological X-ray vision. I don't have that. You say I see things that others don't. I think that's because people offer me a story that they don't offer to other people because of the trust that I share with my patients. But I don't have psychological X-ray vision, and none of us do. So I think the idea that we can always recognize the signs of distress is a bit of a problem with this population, because they are professionally good at compartmentalizing their pain.
Right.
So what I always emphasize with my patients is, I would like you to get to the place where you exercise really what it means when you say that you have this love and trust, that you would lay down your life for your brothers and sisters. What does that love and trust look like in the context of a relationship where you're getting eaten alive and you're not telling anyone about it? And what would it look like to be brave enough to open your cloak to somebody that you love and trust and say, there's a fox here in my gut that's eating me alive, and I need your help with this because I'm not sure I can take this out by myself.
Mm-hmm.
And so really, as a clinician, my goal was always to sort of get to that story behind the story, that
Yes.
fox in their gut,
Mm-hmm.
and to help them create systems and language with each other that help them do that for each other so that they don't get into a very dangerous situation at the end of a tunnel.
Mm-hmm. That's really so important, to be able to voice the fear and the what it is that is so difficult for you. And I know that in one of the stories I was reading this morning, it was there was a man who was saying, a veteran who was saying to you that he basically would rather go into combat than tell his wife, that he loves her as much as he does. I'm sorry, I'm paraphrasing that, but that was so much more dangerous for him. And the way you handled that, I thought was, if you could explain or share that story so others can know what you were talking about, I thought that was really important, because that was a big moment for him. Yeah.
You know that I didn't plan for this, so I actually have a prop here. I didn't plan.
Great.
This is my warrior box that I had here, and here's a parachute cord that veteran gave me. That's probably worth 50 cents, but it's priceless to me because of the story that comes with it. Yeah. And so this is the story. He said, I was trying to coach him, like I did my private practice civilian patients, here's how you have a good fight with your wife.
Right.
Here's how you take that hill and you accelerate into that conflict with someone you love, protect them from your own rage, and do something productive. So I had been talking with him about that. He just looked at me like, you must be crazy. I would rather walk into an ambush than tell my wife that I love her and I need her. And that really helped me to understand how courage has different, there are different forms of courage. Mm-hmm. And that it may be harder to take off your armor with someone you love than to walk into a firefight. In fact, firefights are kind of fun for some veterans. They kind of enjoy, understandably, being in the state of flow, doing what they do as warriors. They look forward to engaging the enemy at times. So not only was it, not something that was, truly frightening for many of them, they actually enjoyed it. Mm-hmm. None of them enjoyed my counsel to go and take their armor off with their wife and talk about what was really going on in their marriage and the disconnect. Mm-hmm. But when they did it, as with this case in particular, it was beautiful, because his face changed in the next session. He came in and said, how did it go? He looked totally different. He looked 10 years younger. The tension lines had dropped. He said, we're having sex again. I was like, cool. How did it go? How did the conversation go? And he filled me in, and he was so brave. And he was able to get to the fox in the gut of that marriage. Foxes don't just try and take us out as individuals. Sometimes they come after our marriage. And there'd be some seed of some trust rupture or some trauma that we've done to each other that each partner wasn't even fully aware of, as often happens. And they unearthed this fox in the gut of their marriage, and they dealt with it as an effective team, and it changed everything. So he came back and he gave me this parachute cord, and he said, this is a parachute cord that worked when the first one didn't. And I don't know if I told you how close I was to, some really bad outcomes. I was really not okay. And I'm okay. I'm okay. So the thing is, people can get into a tunnel really fast in terms of danger to others, danger to self. He was probably more a danger to other people than he was to himself. But they can also come out of that tunnel with the right brave move and the right insight. They can get into a much better place, which is why I know that therapy can really be a game changer.
Yeah. And I think that's so important for the summit. We've been really trying to give veterans alternative therapies, alternative treatments, way to look at things differently, and to know that there is really hope, that not every therapist is going to act this way, that not, your one experience isn't one and done. That's not the way, and we want to let them know who these people are, where they can go, how they can get help. And one of my favorite things I wanted to talk to you about was also the SGB, stellate ganglion block, because at that moment of just incredible despair, where you think, I just can't do this anymore, this treatment, that it just blows my mind that it's an outpatient treatment and that it is so immediate. I'm thinking this should be on billboards everywhere. It is so extraordinary. And I would really love for you to talk about that, because for those that are out there that know nothing about it, it is really a game changer in enabling them to continue with their other therapy, to change. Well, you describe it because you know it so well.
I know it well, but not as someone who's held the needle, thank goodness.
Right.
Nobody wants that role. We'll leave that up to my much more qualified candidates and the medical side of things. But I think what I would represent is that the fusion of this biological intervention that seems to reboot the fight or flight system and restore a sense of calm with therapy is game changing and has been life-saving for many of the patients I've served. The backstory on that is that I had a patient at the end of my time at the VA. It was actually in the VA that I started working with this. Honestly, not without official permission, but it was within the bounds of what the medical provider was qualified to do. And he had done this for pain. So stellate ganglion block is an injection in the neck, a few inches above the collarbone. It's not new. It's been around since 1925.
They used it for hot flashes, right?
Yep. Hot flashes and what's called CRPS, complex regional pain syndrome. So for certain types of pain conditions, pain physicians have used this for, about 100 years. And in the past, since about 2008, it's really started to emerge as a very promising treatment for psychological trauma. The first report was with Dr. Eugene Lipov, 2008. He did a case report on a robbery victim who was about to be admitted to an inpatient unit. So to your point, this is a treatment that can work when people are on the ropes with their demons. It can also work when they don't even meet criteria for PTSD, but have certain symptoms that it really helps to target. And I'll talk about that in a little bit. But he was, this patient had been robbed, was in a really bad place, acute PTS symptoms, post-traumatic stress. And Dr. Lipov treated him and he had this amazing turnaround. So this patient of mine saw this procedure. He was a special forces guy. And it's used in certain special forces units, actually as a go-to treatment for psychological trauma. A lot of the pioneers for this have been, as well as Dr. Lipov being in the civilian setting, many of the pioneers have worked in military hospitals and facilities, Fort Bragg. And I know that you had interviewed Dr. Sean Mulvaney, who has done so much research and practical development of this. So it's, been used for a long time, but this has been an emerging indication of how it can be helpful. And this patient said, I like this shot. You know that I've worked hard in therapy. Can you get this for me? And so I had a fortunate connection with a medically qualified provider who did the research, read the literature and said, I'll do it, and the patient wanted me there in the room. So I was, and I wanted to see it with my own eyes. I really did. So I was grateful that he wanted me there with him. And it was amazing because he just, his whole aspect changed within 20 minutes of getting this injection. And he became tearful. And he said, it feels like somebody just took 1,000-pound weight off my chest. And I followed him for several months. So it wasn't kind of like, a quick, short-lived, he sustained gains. And the therapy that we did, this is the point here, is that the therapy we did took on a whole other level of traction because he was calm and he was able to take in the insights that we were discussing and really apply them in his life. And he just took off. He got on this whole new trajectory in terms of his relationships with his loved ones and how he was navigating the world around him. So psychologists, therapists, mental health providers, we are definitely even more so needed in this window of opportunity that stellate ganglion block creates. SGB is not a cure for anxiety. I will vocally and repeatedly state that, no matter how miraculous people say the results are. You have to do the work. There's no getting around the work because PTS is partly biological and it's maintained by the way that you navigate the world and your relationships. So if you don't have the work of a skilled therapy provider to help you maintain the gains and really change your way of operating, then you'll be back in 6 months and you'll need another injection because the adrenaline will kick right back up.
You'll be re-triggered by something that happens.
Yep.
And I thought that one of the things that I had asked Dr. Mulvaney is I said, well, if somebody is on drugs that are used for mental health, that have sustained them at this point, do they have to titrate off of all of those drugs before you can do this procedure? And he said, no, not at all. And I thought that was very interesting to know because that's usually really not fun to have to do that before something can start. He said, nope, you don't have to worry about that. And also one of the thoughts immediately, I told my sister about this procedure and I said, it is not like you get this anesthetic, can't remember what it's called now, but he told me the name, in your neck, and then suddenly, you're going to go play in the street. You don't lose your fear. You are reset to normal. You are not going into a state of, absolute, nirvana.
Not euphoric.
No. But as he said, just exactly as you described, the response is usually emotional because the feeling of not having that anxiety or stress is so enormous. Yeah. But what creates it around you, you still have to deal with. I mean, you can just do it more calmly and without that horrible. You can hopefully
removal of a huge burden off your back. It's taking 1,000 pounds of weight out of your ruck, which can be pretty interesting,
enormous.
People have emotional reactions sometimes. Others will say, it's the first time I feel calm in my own body for many years. But it doesn't make you euphoric. It is, in a sense, kind of a precision medicine thing because the medication doesn't stay in your system.
Right.
It's a bit like Christine Ray Olmsted talked about it as like Novocaine. She's one of the researchers on the
You mentioned that. Yeah.
It's a good analogy, because it has a temporary effect, but it resets a system, a biological system that makes you feel calm. And so some people may feel a sense of some joy and expansion. Like one of the Marines that we treated recently at Stella Center said, I forgot, he took a walk around Chicago and he said, I forgot how beautiful the world is when my brain stops telling me that it's trying to kill me.
I mean, that's just phenomenal, isn't it? I mean, to think that you could do that in an outpatient procedure, and that it's just hard to see that there's a downside here, to this. And I know that you had mentioned that you have seen this repeated numerous times. I think Dr. Mulvaney said he has done this procedure 1,600 times. But you've seen it also in the response with your patients, that it's been effective.
Not 1,600 times, to be clear. But
no. He did the procedure 1,600 times, but from the therapist's point of view, you've seen the other side of it, which is the longer lasting side of it, where you're seeing them as the provider who watches the difference in how they're able to do their therapy at this point.
And I've seen about 30 of these live at close range, and seen that immediate shift in people when it works. And it's so much fun because the work that we do as therapists, right, is one of the best things about this work is you get to see people transform. You get to see people like go through this beautiful transformation. Yeah. And this works about 80% of the time. So really positive, outcome rates overall, maybe it just is a much more accelerated path to getting them relief. And then the therapy takes off. And that therapy work is fun because they're in the room with you, because they're not there, but not there, they're not
dissociating or whatever. Yeah.
Exactly. So it is really fun to help people kind of like create a new normal and navigate their relationships in different ways. Last time I talked to Sean, we were talking about, he had a really good analogy. I don't know if he shared this with you, so stop me if he did, but I thought it was really important. He said, I feel like we have this thing, like a little flame, and we want to make sure we protect it. And that, it gets the support that it needs to really develop into something that can help a lot of people. Right. So I'm pulled in two directions here, Jane. I want to get the word out that this can be life-changing and life-saving, because I get some of those calls from people who are like, if this doesn't work, I'm done, and it changed their life. But I also want to make sure that we do this in a way that is best practice. And people like Dr. Lipov, like Colonel James Lynch, like Dr. Mulvaney, like there are some people that are really, Dr. Brian McLean out of Tripler, are expert and way, light years ahead in terms of adapting, making modifications, really understanding how to use this with a trauma population. And so one of the things I'm going to be doing is developing out a whole series for educating psychologists and mental health providers what this is about and how to prepare patients, support them during, and follow them up afterwards through SGB in a well-supported, well-informed way. And I'll be scoping that out for Stella Center to provide that to the field as a benefit so that we can build out the continuum of care and patients can be following up with their therapists or find new therapists. Not me, I'm not doing clinical work right now. I don't have bandwidth to take on a caseload, but to see people for follow-up care. So I'll be doing a lot of that training.
That's wonderful.
Yeah, and the other thing is that people like the Lipov and Mulvaney's, Lynch, they need to be involved in training people. Because the worst thing that could happen is if you get an unskilled or unqualified provider and they get some rare side effect, which causes fear about something that actually the VA Office of Compassionate Care calls a safe and ethical treatment.
Yeah,
It should be safe. And when you're using the right tools, the right techniques, and the right training. So the other thing is I would argue for people not to just start, injecting people, really to think about getting trained by the pioneers in the field and doing it
Yes,
the right way so that it can really.
absolutely. Yeah, absolutely. And one thing you wanted to mention too was that the PTSD Act.
Yeah.
Um,
Yeah.
I'd love to have you share that because that's really good news.
Thank you. Congressman Scott Perry proposed the Treat PTSD Act. He is a representative of Pennsylvania. And as of this morning, something came across my desk that there are 5 co-sponsors of the Treat PTSD Act. So hopefully momentum is building, but this would make stellate ganglion block available to veterans that elect to have this treatment as part of their treatment plan, as part of their VA benefits. So it would be incredible if this gets passed. And, I am working with Congressman Perry and his team to see if we can get this done. Working at Stella Center, we are providing stellate ganglion block, but they said it's the right thing to do to work on getting this passed. No matter what impact it has, it's the right thing to do. They gave me their blessing. And so I am trying to get this done because it's not political for me. It's a moral imperative that we make options available for people who want them for relief.
Mm-hmm. And it's so far reaching. As we were discussing, for children who have suffered severe trauma, for sexual assault survivors, for veterans, for anybody who has had this kind of a traumatic response that has destroyed their ability because of that being triggered to calm themselves. And this is just remarkable, absolutely remarkable. And I could spend forever talking to you. I should move to Chicago. I just really, there's so much, but I would love, just in closing, if you could share anything that is, if someone says, I'm just tuning in and I'm really struggling and I just don't know what to do. What is the hope from what you've seen with the many wonderful outcomes that you have had with people that have gotten the right therapy, they can certainly read this book and learn a lot about themselves, but how can you help them to hang on and know that there's hope?
Because there's hope. Because there is hope. And one of the films that is coming out on Veterans Day, Michael Geyer is the producer. It's called Wounded Heroes. Mm-hmm. And what he did is he went around the country and did profiles on different alternative therapies. Stellate ganglion block was one of them, but he also profiled, I remember there's a equine therapy.
Yeah.
And just other modalities of treatment.
Yes. Like doing what we're doing, with the summit, and we're also going to put link to his film on the website so people will know about him and all the work he's doing, because it was fantastic. That film is great.
Yeah, I was just invited to join Rally Point, and it was a Colonel Burroughs that invited me to join. I didn't even know that civilian supporters were able to join. And it's not my great push in without an invitation, but I just started on Rally Point. So I would absolutely welcome people to connect there and link up with me there. The only kind of thing I have to look out for is that I never want to be unresponsive, but I'm pulled in so many directions right now that I can't offer like individual advice or therapy. So sometimes I get a little bit reluctant to kind of engage because I get a flood of kind of, what should I do with my relationship? Should I leave my wife? I'm not going to respond to those kinds of inquiries, but if you want to learn, where to get stellate ganglion block, I have tons of resources. I do a weekly Military Times podcast with Dwayne France called
Wonderful
Suicide Solution. We've interviewed tons of really expert guests and veterans and people that have something to say. And so I hope that those who watch this will connect with me there in the tribe. And I'm really grateful for what you're doing here, Jane, and really kind of getting good information out there, and appreciate your support of my work and my book, Warrior.
Wonderful. Well, thank you so much, Doc Springer. What an honor to be able to talk to you. And I look forward to many more opportunities to spread the word about Warrior and all the good work that you're doing. And we'll certainly put all the links and all of the information and a click through to everything so that people can find the book and find you and the work you're doing at the Stella Center.
Thank you.
Thank you. Thank you so much. And I hope I'll see you soon.
I'm sure.